Hello, welcome to R.K Medicos. Now I am going to start our third part of the pharmacology. Basically, we discuss in pharmacology now the pharmacokinetics. In pharmacokinetics, I discuss there are four parts. Basically, we discuss absorption, distribution, metabolism, and excretion. In the first part, second part, or the now it's third part. In the third part, we basically discuss the third one. In the pharmacokinetics, there are four parts. In the four parts, the absorption we discuss in the second part of our pharmacokinetics topic. Now in the third part, we discuss the distribution and in the fourth part we discuss metabolism and excretion both alone. Now we discuss what is pharmacokinetics. As we discussed from the previously, pharmacon means that is drug and kinesis means that is movement, the movement of drug in our body. Absorption we know now very well in the second part of the pharmacokinetics. Now we discuss about the third part. In the third part, we discuss basically a whole topic about the distribution, how the drug is distributed in our body. First, we take orally, the drugs is going into the stomach. After that, they are going to the movement in intestine. They are gets absorbed in our body. That is the distribution, and they coming into our blood circulation, in the systemic circulation, and after that they get distributed in our whole body, in the whole organs, the different parts of our body. These drugs are get distributed. So there is some hypothetical parameter to calculate what the amount of drug we take is coming into our circulation, that is blood circulation, and then distributed to our tissues, then distributed to our different organs of the bodies. So we are going to discuss about the pharmacokinetics here. In pharmacokinetics, we discuss basically distribution of the drug. We discuss basically distribution of the drug in the second part of the pharmacokinetics, and in which we discuss what is the apparent volume distribution. We discuss mainly what is the apparent means exactly it is the hypothetical parameter. Apparent means maybe something it's possible, it's expected कि there is a distribution of volume is happened, it is expected. It means it is a hypothetical parameter. Okay, it is the hypothetical parameter. As we see now, it is the hypothetical parameter. Now next topic we discuss in it is the definition. What is pharmacokinetics? The basically in distribution I am going to prepare some slides for you to see here. Suppose that there is any person, suppose that this is any person head, suppose that this is his body, and these are the his leg portion, and these are the hand portion, suppose, and this is the blood vessel. Suppose that this is the central blood circulation in his body, and from inside it the drugs are present. It means we take drug, the drugs is going to the stomach, then they gets absorbed into the blood circulation, and they coming into our blood circulation. So what is it? It is the drug which is inside the blood vessels, inside the blood vessels inside the systemic circulation, basically. What happened after that? They are moving, these drugs are moving to the different parts of our body. These drugs are moving to the different parts of our body in the different organs. Suppose that in the thorax region they are distributed to the lungs, heart, or the different regions. In the abdominal region they are differentiated or distributed to the liver, they distributed to the small intestine, large intestine. Like these parts are going, these drugs are moving. They are moving into the hand also through the blood systemic circulation, and they are moving into the head region, they are moving into the leg. Different parts, these drugs are moving. These drugs are moving. After the distribution of drug, how we calculate where the drug distributed and how much in amount, how much the amount of drug is distributed and where is it. So for which there is a hypothetical parameter is included, that is the apparent volume of distribution. It means expected what the amount of volume is distributed in our body. There is a definition for that. What are the total blood plasma in our body? What are the blood plasma? Inside the blood vessels, the blood is flowing. Inside the blood, red blood, white blood, and the platelets are present. Except it, these all the cells are excluded from them, and what the plasma content is living inside this plasma, how much amount of drug is present, that is the total plasma concentration. total plasma concentration, and what is the dosage of drug is inside it. That is the also called as bioavailability. We can see here some term is representing here, that is the bioavailability. What is bioavailability? Bioavailability is an important term. Basically, we now see there is a fraction of unchanged drug. Fraction of unchanged means what we amount of drug is taken, they reaches to our systemic circulation. That is the bioavailability of that drug. And understand, these drugs are gets absorbed where? In the blood circulation. And this F is representing here the bioavailability. Bioavailability is directly proportional to the absorption, means what the amount of drug we take in the stomach or maybe absorptive surface area. The absorption of all these drugs are called as bioavailability of the drug. Means any drug is having written the bioavailability is 100%, it means the drug are taken is 100% absorbed in our body. After that, the second part, they are inversely proportional to first part, metabolism. Their catabolism and anabolism, it means their breaking down activity will be inversely proportional. When these drugs are absorption is 100%, then it will be metabolism will be less. It means it is true. Now we discuss about the total plasma concentration. What is the volume of distribution in it? In the volume of distribution, they accommodate in the body of the patient. We can again see here. Suppose that here is the liver is present in the patient. This liver, here is the liver of the patient, and we are going to measure inside the liver what happened, what amount of the drug is present. So for this purpose we use the hypothetical parameter, and that is, what is the hypothetical parameter? Is it apparent what is it? Apparent volume of distribution. It is the distribution of drug inside the different parts of the body in a specific volume of our body. We can see here it is the total plasma required to accommodate the administered dosage of drug in the whole body in the plasma concentration. In the whole body we have plasma inside the blood vessels. In that plasma of the blood vessels, the administered drug is reaching, and what the amount of that administered drug is representing as apparent volume of distribution. Now we can see what are the volume of distribution, apparent distribution, and the loading dose. What is loading dose and what is apparent volume? Their formula for it. This is not much informative for us. They are basically don't know what here we have to memorize from here is just what is the volume of distribution formula and what is the definition. That's all for now. And that is the intravenous route. How we can calculate the patient taking intravenous route? It means not this is orally. Intravenous route is injecting inside the veins. It means the intravenous route, what happened if the patient is having taking. So the dosage of drug is representing D here. So the dosage of drug is representing D here, and C is the concentration of plasma. Suppose that in our body the concentration of plasma, what is inside the blood, we inject the dosage of drug. This is what is the amount of distribution from their plasma to the different parts of body. That is called as what? Distribution of volume of the drug. Another route, there is the once again the dosage of drug and concentration of plasma into bioavailability is representing the any other routes. When we taking the drug intravenously, then it will be correct. That is, dosage of drug is directly proportional. They are divided by the plasma concentration or the concentration of plasma. But in other routes, maybe we've taken the orally, maybe we've taken the intramuscular, or the other routes we take, then it will be the bioavailability multiplied by it, and it representing the volume of distribution formula. Next, loading dose. What is the amount of blood is loaded inside our plasma and then distributed to the body? It is called as loading dose. Basically, loading dose is directly proportional to the apparent volume distribution. Means what is the amount of volume distribution in our body is also directly proportional to the C, that is concentration of plasma. It is representing it, and it. Now we see another one. The loading dose is the dosage of the drug which is injected inside our plasma concentration and that distributed in our body. That is the loading dose. Also we can see here the drug which is high volume of distribution, means what are the amount of drug, their volume of distribution is higher, means they are distributed in our body higher amount, should be administered in the higher dose. Why? They maintain the specific plasma concentration. Inside the plasma, these drugs are going and they're distributed in the body. These are information about the other routes. We can see two formula here. That is the loading dose formula and the loading dose another formula. When we injected by the intravenous route, then the formula is apparent weight, volume of apparent distribution into the concentration of the plasma. And when the other routes will be injected, then it will be the divided by bioavailability. That's all about. Just we discuss about the formula, but we have to memorize only definition and some not different things. The factors affecting the volume of distribution. What are the factors that affecting the apparent volume distribution? What are the factors that affecting the apparent volume distribution? Suppose that the patient is having some taking the drugs, and inside our body the drugs are reaching to the plasma. After that, these drugs are gets distributed in our body. So what happen? What are the factors that determining the how the drugs are gets distributed in our body? The first one is the lipid solubility. What is the lipid? Lipid solubility. Each and every cell is made up of the lipid. We know the lipids. Then what are the amount of lipids is present in our body? It also depends what are the drug is moving inside or outside the cells. That it means the amount of lipid is more in our body, means volume of distribution is more, because lipid soluble drugs, the volume of distribution is more is when the lipid solubility is more. The more lipid soluble is more volume of distribution. Next point is the fat content in the patient. When any patient is having fat content, suppose that the patient is having obese, the obese patient is having more fat, more lipids, more fatty tissues, more adipose tissue. It means more fat once again. It means more volume of distribution once again. Suppose that the patient is athlete. What happened to the athlete? When the patient is athlete, they are the thinner, they are the lean, there is a less fat, less adipose tissue. It means there is a less lipid. It means volume of distribution is decreased. It means the blood, inside the blood, the drug is administered. What the amount of drug is present, they are gets distributed very less. Next, third point, the gender. In the female, the muscles are plummy. It means the plummy muscles or the plumpy muscles, they are more, they are thicker. The female muscles will be thicker or they are the plummy. It means the adipose tissues are more deposited in the female, in outside the body structure. And that's why the female is having volume of distribution will be more. Next, fourth point is the age. Age will be also determining. The elderly patient, the volume of distribution will be more, and younger is having less. What is the plasma binding protein here doing? The plasma binding protein is inversely proportional to volume of distribution. Suppose that we can see here what happened in the plasma binding protein inside the blood vessels. Suppose that this is our blood vessels. Suppose this is the blood vessel, and inside it there is some plasma proteins are present, and the drugs are moving inside it. The drugs are moving inside it. The green one is plasma protein, and dotted blue one is our drug. Suppose that these plasma proteins are binding these drugs. It means what? The drugs are not moving out. It means these drugs are not moving out, or they're moving very less. These drugs are not moving out, or these drugs are moving very less. Why they are moving very less? When the drug are moving very less outside, it means their volume of distribution will be decreased. It means the plasma protein, the binding plasma protein BPP, the binding plasma protein is directly or inversely. It is the inversely, of course, inversely proportional to the volume of distribution. When the amount of drug is binding to the plasma protein will be more, it means less distribution of volume, and when their binding will be decreased, it means more volume of distribution. It is, of course, it is true. And next point is the tissue binding. Some drugs in our body is having higher affinity for some special type of tissues. Suppose that in the cardiac patient, we basically in the arrhythmia patient, tachyarrhythmia patient or the arrhythmic patient, we take a drug that is name is digoxin. Digoxin is the drug which is basically acting as an anti-arrhythmic drug we can use. What happened with these drugs? when we take these drugs are acting on the sodium potassium ATPase pump, and sodium potassium ATPase pump is everywhere in our body. We know about it. And what happened, these drugs are bind to these channels, sodium potassium ATPase channels. So in the skeletal muscles, having the higher affinity to it, so it can affecting the higher affinity for the skeletal muscles because they are present in higher amount. So we can see, and the loading dose is based on the basically in the low body mass content. That's all for now. And in the factors affecting, that's all. And factors determine the apparent volume of distribution. We know the 4: lipid solubility, fat content, plasma protein, and the tissue binding. Next we discuss now. Next is the drug toxicity. What is the application of it? We are discussing now the volume of distribution in our body. What happened to the volume of distribution? The drug is distributed from the blood vessels. Suppose that we discuss example this one. Their distribution will be less. The distribution of drug will be decreases here. The decreases in distribution of drug. And what is happen? Suppose that the drug toxicity. What is the drug toxicity in the patient? The patient is taking drug. Yes, the patient is taking drug, they reaches to the plasma in the systemic circulation, and this blood in these drugs are not gets excreted out from the body. It means what? These drugs are not excreted out from the body. It means they accumulated inside the blood vessels and they produces toxicity. Our blood vessels are gets toxic now, and the blood is gets toxic. So for which we use the dialysis technique. Dialysis means for the clearing, they are the filtering agent, like acting the filtering machine, that is dialysis. We done dialysis for the patient is having drug toxicity. When some drugs have toxicity, we can't remove from the dialysis, for which we use antidote. Specifically we use antidote because some drugs having many of the drugs are gets excreted out by the kidney, by the liver, or by the lungs, like this. But some of the drugs are not excreted out. They produces toxicity in our body. For them we use antidote for the removing, and they are not removing by the excreted through them, by the kidney, by the lungs, by the liver. When the drugs are used in the dialysis, what are the drugs are removed by the dialysis technique? These are acting as an exogenous kidney. And next point is, what is the dialysis is effective or not? The dialysis is effective, The dialysis is effective or non-effective. When the dialysis is effective and when the dialysis is non-effective. So now we discussed previously, when the filter drugs or the toxins present in the plasma, what are the drugs is present in our plasma or the blood vessels? Inside the blood vessels, what are the drugs are present? That can be filtered throughout the kidney, that can be filtered throughout the liver, that can be filtered throughout the lungs. Then it will be helpful and it will be effective in that manner, the dialysis. But when the non-effective, the dialysis gets non-effective. Suppose that the drugs are binding to the plasma protein, it is effective dialysis? No, because in the dialysis we can't remove the plasma protein, and these drugs are binding to the plasma protein, so it can't be removed. It means they are ineffective, or they are ineffective, or the not effective in case of higher binding of plasma protein capacity. When the drug is having higher capacity for the binding of plasma protein, then it will be ineffective or the not effective. Next point, when the drug is having higher amount of volume of distribution. Suppose that the drug is coming inside the blood vessels, they are moving inside the bodies, different parts of organs. Then this body are distributed, the distribution of drug in our body is can't accumulated in the blood vessels again, they gets excreted out. Then there is a higher volume of distribution of drug. It means higher they are reaching to the organs or the peripheral part of organs, they are leaving the blood vessels. It means they are not coming again to the blood vessels. It means they can't be excreted permanently, they can't be excreted all the blood vessels. It means their concentration will be increases in the tissues and decreases in the plasma. So these drugs are not what? These drugs are not dialysis. Dialysis is effective in these drugs? No, because in the dialysis we mainly filter the bloods. We didn't filter the tissues. We didn't filter the tissues plasma. We filter mainly the blood vessels. Inside the blood vessels, what are the bloods are present, what are the plasma are present, that can be filtered through the dialysis. That's why it is not effective in it. Next point we discuss, what is the drugs are binding to the irreversible manner. There is just some drugs which are binding to their receptor in the irreversible manner. These drugs are going to the receptors and stick to them. They are not coming again. They are not removing from the receptor. They gets bind to it and they gets accumulate in our tissues. They produces toxicity. They are not effective. The dialysis is not effective in this case also. So what are the drugs? They are not use dialysis. The dialysis is not useful in these drugs. Some drugs are listed here. Some drugs are listed here. We can see now some drugs are listed here in which the dialysis is not effective. Some drugs are listed here. The dialysis cannot be effective in the mentioned above drug toxicity. And what are the drugs? Is it the first drug is for this drugs? There is a trick for you. There is a bad doctor. The trick is bad doctor. We can see here the bad doctor. The bad doctor, the B stands for the benzodiazepines and the beta blockers. The A stands for the amphetamines. D stands for the digoxin, and another D and O stands for the opioids and organophosphate poisoning, and the C stands for the calcium channel blockers. So there are the 6 drugs basically. There are the 6 drugs basically which are useful, or which are maybe useful for us to memorize them. The dialysis cannot be effective in these drugs. The first one is benzodiazepines. The first one is benzodiazepines, beta blockers for the B. A stands for the amphetamines. D stands for the digoxin. Another D and O Dr. Cardio. D stands for the opioids and organophosphate, and C stands for the calcium channel blocker. We have antidote for them. We can't use dialysis for their elimination. So we can use what? We can use antidote for the treatment. We can use antidote for the benzodiazepines. We use basically for the benzodiazepines we use flumazenil. Flumazenil is the drug we given in the patient is having toxicity of the benzodiazepines. Next one, when any patient is having the toxicity of the beta blockers. Beta blocker toxicity, we give glucagon. Why glucagon given in the patient is having? Why glucagon is given the patient is having toxicity with beta blockers? We discuss in the antiarrhythmic drugs basically. But for now we have to memorize the beta blockers is given for the antidote in the glucagon. Now the third one is amphetamines. What is the drug toxicity of amphetamines? The antidote is given ammonium chloride. We have to memorize it. Ammonium chloride is the antidote for the amphetamines drug toxicity. When the patient is having digoxin toxicity, we use Digiband. Digiband is the drug and the patient is having digoxin. Opioids, naloxone and naltrexone. Organophosphate, atropine is the antidote. Calcium channel blocker, we use calcium plus 2 gluconate. The calcium plus 2 gluconate is using calcium plus channel blocker. These are all about the application of it, what we study about the drug toxicity now. Next point is the plasma protein binding drugs. What is the plasma protein binding? Just now we discussed plasma protein binding is inversely proportional of the volume of distribution. We discuss now. The plasma protein binding drugs means what are the drugs which are binding to the plasma protein. What are the proteins which are present in our plasma of the blood vessels, and inside the blood vessels the protein plasma are present and these drugs are binding to it. And what are these proteins? They are the 2 proteins through which the drugs are binding. The first one is albumin. Memorize it, albumin, and the second one is, first one is albumin. What is it? Albumin, and the second one is alpha-1 glycoprotein. The albumin and glycoprotein are the 2 proteins in our plasma which is responsible for the binding of drugs. Albumin is binding basically, A stands for albumin and A stands for acid. A stands for albumin and A stands for acid. The A stands for albumin protein is present in our plasma which is binding basically the acidic drugs. What are the acidic drugs? The acidic drugs are the different examples we discuss now, but next one is the alpha-1 acid glycoprotein. These are the basic. Alpha-1 is the basic. Both are A, but we have to memorize one. Albumin is binding with the acid. It means alpha-1 glycoprotein will be binding to the basic or the basic drugs. So we have to memorize there are the two types of protein which are present in our blood vessels or the plasma concentration which is responsible for the binding to them. So what are the plasma protein drugs? What are the plasma protein drugs? Basically, what are the plasma protein drugs? They are binding to the albumin or the acidic drugs, CNS drugs, antibiotics, NSAIDs, non-steroidal anti-inflammatory drugs, warfarin and aspirin. What are the five classes of the drug? First, CNS drug. Second, NSAIDs. We can also say antibiotics, NSAIDs, warfarin and aspirin. Aspirin, warfarin, NSAIDs. Next one is the, you can tell me, CNS drugs and then antibiotics. CNS drug is basically representing as the antipsychotic drugs. Antipsychotic drugs are basically used in the schizophrenic patients, or the antipsychotic is used in the psychosis of the patient. When any patient is suffer from the psychosis, then we use antipsychotic drug. Next one is anti-epileptic drug. Epileptic drug is basically used in the seizure. The patient has myoclonic clonic seizure. This type of seizure will be happen the patient. These drugs are used anti-epileptic. Next one is benzodiazepines. Benzodiazepine drugs, these are the drugs which acting on the benzodiazepine receptors. That is benzodiazepine receptors. That is the classification of group on the basis of the receptors. The antibiotics are used to sulfonamides and penicillin. These are the two antibiotics which are also acting on the albumin protein of the plasma, or they are the acidic drugs. Next one is NSAIDs, non-steroidal anti-inflammatory drugs, or the warfarin and aspirin. So these all are the five group of drugs which are the acidic drug. They are binding to the albumin in the plasma protein. So next one is the alpha-1 glycoprotein drugs. They are the basic drug. There are the three groups of drug here. They are the TCA tricyclic antidepressant or the opioids and the antiarrhythmic drugs. Antiarrhythmic drugs we discussed. That is the first one is the beta blockers, amiodarone and lidocaine. The lidocaine, amiodarone and beta blockers are the three drugs which are used into the, these are the beta blockers, amiodarone and lidocaine are the drugs which are used in the antiarrhythmic. Antiarrhythmic, they are the treatment of arrhythmia. The patient is having tachyarrhythmia, the patient and tachyarrhythmia, bradyarrhythmia, these are the drugs will be used. Basically, we discuss in the antiarrhythmic drugs and the opioids, morphine, codeine, like this. They are binding to them, or the different types of drugs will be included inside it. And the tricyclic antidepressant drugs will be also used. And they are binding to the basic drugs, are binding to the alpha-1 acid glycoprotein. It is true. It is pretty true. Next one is A. A we discuss now. A is this one. We can see here A part and this one is B part. What happened to the A part and what happened to the B part? Suppose the any patient is having a decrease in the amount of albumin. Suppose the any patient is having decrease in the amount of albumin. Albumin is the protein which is binding to the acidic or basic drug. That is acidic drug. And acidic drug we know now. The patient is having decrease in albumin. Suppose that the patient is having decrease in albumin in his body. The plasma protein albumin will be decreased. It means acidic drug is not binding to it. It means decrease in albumin will be leads to increase in free drug in plasma. This plasma, suppose that this is the blood vessels. So this is the blood vessels. Inside it the drugs are present. And suppose that this is the plasma proteins. Green one is plasma protein and these are the drugs. The drugs are not binding to it because the decrease in the amount of what? Albumin. Albumin is decreased. And we know in the acidic condition the albumin is binding to it. The drugs are free in amount. The more drugs will be free. The more drugs are free present inside the blood vessels. Inside the blood vessels, the more drugs will be free. What does it mean? The more drugs will be free in plasma, it will be create more toxicity. When the more drug is present in our blood vessels, free form, it means they are moving freely in our blood vessels. They are moving freely with our blood. It means they produces more toxicity. Now the second one, what happened to the patient is having developed nephrotic syndrome, cirrhosis of liver and the chronic kidney disease. In these three types of diseases are albumin proteins are decreased. The patient suffer from nephrotic syndrome, the albumin concentration will be decreased. In the cirrhosis of liver, chronic kidney diseases. Next point is what happened to the patient is having increase in alpha-1 acid glycoprotein. This is binding to which type of drugs? Basic drugs basically. And what are the group of drugs we discussed? Tricyclic antidepressant, also opioids also, and the antiarrhythmic drugs. Antiarrhythmic drugs is having amiodarone and tell me beta blockers. Good. We can see here the alpha-1 acid glycoprotein. Alpha-1 acid glycoprotein is binding to the basic drug basically. When these are binding to the basic drug, they're decreasing the free drugs. They are binding to the basic drugs. Suppose that their amount is increasing. It means their amount is increasing in the plasma. They are leads to binding the more drugs. It means they're binding to more drug. It means less amount of drug is free. The less amount of drug is free. It means less toxicity. It means less amount of free drug means less toxic. It is true. It is pretty true. The amount of less will be binding. When the plasma protein is binding, whatever the plasma protein is, don't worry. Whatever the plasma protein is, don't worry. But what the amount of drug is binding to it is responsible for the toxicity. When the free amount of drug is more toxic. Less amount of amount of drug is less toxic. There is in rheumatoid arthritis, inflammatory disease of bowels, in the bowel diseases and the myocardial infarction, these three diseases, the patient is having higher amount of glycoproteins in it. This is all about the distribution of drug. And hello everyone. Now part 4 of our video is start now, and in which we discuss pharmacokinetics is basically in which we discuss metabolism and excretion part of the pharmacokinetics. Pharmacon drug and the kinetics means movement, that is movement of drug as we know, and these are the metabolism and excretion will be discussed. What is metabolism? The metabolism of drugs is basically what happen inside our body. In our body we should take a drug, and what happened to these drugs? These drugs are components are divided into the simple particles and they distributed in our whole body. After that, the usage of these drugs, the body gets metabolize them. And the biotransformation, the another term is biotransformation, is basically the transformation of drug from one form to another form. What does it mean, biotransformation? It is basically means the conversion of more toxic substance into less toxic substance. In the one word, we are going to convert the more toxic drug into less toxic drugs, and then it excreted throughout the body. Then it excreted from the body. So for the excretion from the body, we doing like this. These are metabolism of the drugs is basically done in the two phases of our drugs. We can see here in the pharmacokinetics we are discussing metabolism here, and in metabolism the phases of metabolism is two: phase 1, phase 2. What happened in phase 1? What is phase 1 and what is phase 2? What is biotransformation? We discuss now. In the phase 1 we can see basically there is the drugs should be entered in our body, and it is present, and it can be break down by the body. The drug can be break down and they can be converted into the less toxic substance, and they gets inactivated. Suppose that the drug particles is activated in the wrong manner, it can be broken down, it is inactive or the inactive, the drug is gets inactive, they are not more useful for us, then it can be excreted out from the body. The some exceptions, after the drug is gets broken, it is happen in the phase first, but some drugs are gets broken, after that they will be activated. These drugs are called as prodrugs, and the prodrugs are the drugs which are after the breaking these drugs are also gets activated form. And these drugs are, some of these drugs we have to memorize because these are the several drugs which are activated after the breakdown in the first phase of our metabolism. These are the levodopa. Basically we can see here what are the exception. The first one is levodopa, clopidogrel, and the famiciclovir, and the carbimazole, and all ACE inhibitors, all ACE inhibitors, in which except to captopril and lisinopril, ACE inhibitors. After that we can discuss what happened to these breaking drugs, the breakdown of these drugs. After that they gets inactivated. Suppose that this is the drugs, these drugs are get broken down into two parts and they gets inactivated. These inactivated drugs are going to be attachment of the functional group. There is the attachment of functional group on these drugs, means this is the drug, there is the attachment of something, there is the attachment of some part, and this is the suppose that functional group. This is the functional group. Suppose that what is attaching here, functional group is attaching on the drug, and now this drug is called as first phase completion. At the completion of first phase, the drugs are get broken down, they attach to the functional group, are added on it. These are called as first phase completion, and the conversion is called as conjugation. Conjugation why? the broken down part of the drug is gets attached to the functional group, and this functional group attachment is called as conjugation attachment, and this conjugation is now called as the second phase. In the second phase we see conjugation. Inactivated drugs, they are attached with the functional group and they forming the conjugate. Conjugate means they are basically negatively charged. So the breaking part of our drug, or the broken parts pieces of our drug is part, they're combining with the functional group. After that they gets conjugate form, they gets conjugated. This conjugation means they are having charge something and they are negatively charged basically. And we know from the first part of our drug where the absorption we discussed, there is ionized and unionized drugs. When the drug gets ionized, it will be more absorbed or less absorbed. It will be water soluble or lipid soluble. It will be water soluble, and it will be water soluble, then it will be excreted out from the body. It's get not absorbed. When the drug gets lipid soluble, it will be crossing the membrane and then reaching to the circulation. But when they are water soluble, they are excreted throughout the body, because they are the water soluble. Why water soluble? Because they are the charged particles present on the drug. And this is what we are doing here in the metabolism. In metabolism, we are making the drug more water soluble. We are making the drug more ionized. We are making the drug more conjugated form. Conjugated means more negative form. And then water soluble drugs are gets excreted out. They are coming like this systematic way, and they excreted out from our body. From our body, these drugs are get excreted out. So this is all about the metabolism of the drug and their phases and excretion. How the drug gets excreted from the body. Phase 1, phase 2. Phase 1 is having only breakdown. Phase 2 is having conjugation, attachment, and they conjugated, they provide a negative charge on it, and after that there is a ionized form is excreted throughout the body. We are seeing here some relation to the drug metabolism. Suppose that there is a drug is metabolized in our body. What are the processes? They are related to the metabolism of the drugs. The metabolism of drug is basically done by the several ways in the first phase and second phase. In first phase, what we are doing? Breaking down of the drugs. In the breaking down of the drugs, for which we use one enzyme that is called as microsomal enzyme. And microsomal enzyme basically it is present on the endoplasmic reticulum of our cells. Each and every cell having endoplasmic reticulum, as we know, they are the cell organelles inside which microsomes are present, and inside which microsomes there is a microsomal enzymes are present on it. And these microsomal enzymes are basically present, most of them of the microsomal enzymes are acting on the phase 1. Phase 1 means breaking down of the cell. Sorry, breaking down of the drugs, metabolism. And in second half part, there is no any microsomal enzymes are used. It means except one, glucuronidation. In glucuronidation, there is a microsomal enzymes are used, and all other parts of the second type of phase of metabolism, there is no any requirements of microsomal enzyme. What we are discussing, we don't understand. Listen once more. We are discussing here how the drugs are metabolized. What are their parts? How their drugs are metabolized? There are several processes through which the drugs are metabolized. In first phase, we have several processes with microsomal enzyme. In second phase, there is several processes without microsomal enzyme. In the first phase, there is several processes with microsomal enzyme are mentioned here. And for them memorizing, we have a trick. The trick name is ORCAD. What is the trick? ORCAD mein double A, that is ORCAD. O stands for oxidant. We oxidize the drug, we reduce the drug, we cyclization of drug, hydrolysis of the drug, aliphatic attachment of the drug, aliphatic hydroxylation, aromatic hydroxylation, and deamination. There are the 7 processes which is responsible for the drug metabolism in the first phase. In the second phase, we have mainly 6 processes through which we are going to metabolize our drug in the second phase. In second phase, we just attaching our groups and metabolizes to them. In first phase, we also use several enzymes. What are they called as? Microsomal enzymes. I discussed now, and we also told you that in the microsomal enzymes, in the second phase is used by only one part of reaction, that is glucuronidation. That's all. Second point is here, this is first about the reaction. Second point is it, in the first phase we use microsomal enzyme, is okay. But what is the most common process through which the metabolism in the first phase is occur? In the first phase of our metabolism and in the second phase of our metabolism. In first phase, the most common is oxidation. This is bhankar important. That is oxidation, and in the second phase there is a glucuronidation. These are the two most important reactions through which metabolism of drug is happened, and they are the most common one. Now what are the enzymes mediated in the drug metabolism? As we discussed, what are the enzymes mediated in which phase? First phase. In first phase, enzyme is mediated. What is the name? Is CYP450, cytochrome P450. So what is the enzyme name? Is cytochrome P450. Now it is tell me the cytochrome P450 enzyme, which is what type of enzyme? Microsomal enzyme. Where it is located? Endoplasmic reticulum. And in second phase, microsomal enzyme is used. Yes. In which type of reaction? Glucuronidation. Microsomal enzyme is present or used, and all the other reactions have no microsomal enzyme, and all the other reactions having no microsomal enzymes are used. As we discussed till now, there is no microsomal enzymes are used in the phase 2. Then now we are going to study in detail what is the drug metabolism. What is the metabolism of drug in first phase? How they metabolizes the drug? So we use microsomal enzyme CYP450. CYP450, what does it mean? What is CY? What is P? What is P450? CY is cytochrome, that is heme protein, and they bind to the oxygen, O2. And the P450 is a pigment. What are the amount of light they get absorbed? 450 nanometer. We discussed already cytochrome P450 enzyme. Next one we discuss what are the family, what are the types. There are the cytochrome P450 enzyme is having several types. It means suppose that like this is the cytochrome P450. Suppose that this is the enzyme cytochrome P450. Wait. Suppose that this is the enzyme cytochrome P450. There is having several types. It means it like this. One is like this. One is like this. There is something changes inside it. It means this is CYP450 enzyme, but there is having several types. There is having several types on the basis of the structural components and their family, their subfamily, their differentiation. We can see here the types of CYP450 is having, basically we can see here. What does it mean CYP450 types? The first type CYP450 means till here cytochrome P. After that, 1 is representing here family, A is representing here subfamily, and 2 is representing which gene is responsible for the formation of this type of enzyme, the gene number 2. There is several types, not only one type, there is several types. And these cytochrome P450 enzymes are responsible for the drug metabolism. These are responsible for the drug metabolism. It means suppose that there is a cytochrome P450 type 1. It means CYP, this one CYP182. CYP182 is the type of cytochrome P450 enzyme through which several drugs are metabolized. We can see here what are the drug that is metabolized by this enzyme CYP450. CYP450 types first CYP182. There is a tamoxifen, tacrine, and theophylline. These are the drugs which are metabolized by them. Next type is CYP2B6. This is another type of cytochrome P450 through which cyclophosphamide and methadone. These are the two drugs which are metabolized by them. There are the several types and several types of cytochrome P450 through which the drugs are metabolized. The different types of drugs in our body we take, these are metabolized by the different types of microsomal enzyme which are present in our body, which are present on different types of cells of the inside the endoplasmic reticulum of our cell. So they are the listed here. We can see the list are coming here till 5. We can see now. There is the first one is CYP1A2, 2B6, 2C9, 2C19, and 2D6. So they are the most important one is this one, and next 7 one. All others are not important for now. Till say undergraduate, these all are used in the PG levels, but we are discussing here cytochrome. We have to memorize cytochrome 2C19 and CPY3A4. The 3A4 is most common. Why is 3A4 is most common? 3A4 is the most common because it metabolizes the 50% of all the drugs. What the drugs we take inside our body, they gets metabolizes in the more toxic to less toxic and then excreted throughout the body is the 50% of that drug. All the types of drug, what we take, different types of drug in the different patients, these all the 50% of drugs are metabolized by the one and only CYP3A4. CYP3A4 is metabolized 50% of our drug, and it is the most common enzyme of the cytochrome P450. It is okay, maybe it's okay. Next one is drug interaction. Drug interaction on the basis we are not going to discuss here now. Now we are going to discuss about the excretion of the drug. What is the excretion of the drug? Basically, after the conjugation of the drug gets ionized and conjugated form. They are negatively charged. They do not get the lipid soluble. They are the insoluble in the lipid. They are the water soluble. Then they get excreted. They are the excretion of drug. They are the basically by the three regions: kidney, liver, and the lungs. As I told you previously, there are three regions in the body. They are the responsible for the excretion of drug. Only three regions. They are the lungs through which lipid soluble drug. What are the drugs which are lipid soluble? They are excreted throughout the lungs, through our respiratory system, throughout inspiration, expiration. These drugs are get metabolized and excreted out. So these are metabolized into CO2 form and they get eliminated and in the exhalation form. What we exhale? Expiration of air from outside. From inside to outside air, that is exhalation, through which the elimination of CO2, and in the CO2 there is a lipid soluble metabolism of drugs is get excreted out through the lungs. Next one is liver and kidney. Liver and kidney are basically responsible for the water soluble drugs. In the first part of our video we discussed two types of drug, water soluble and lipid soluble. Lipid soluble drug are excreted throughout the lungs, CO2 format, and the first two, the kidney and liver, excreted the water soluble drugs. In the two ways, the kidney can removing the drugs in the two ways: glomerular filtration and tubular secretion. Glomerular filtration means there is a filtration of drug from the glomerulus of the kidney of nephron of our kidney. It means in the glomerular filtration, the drug gets filtered from the glomeruli of our nephron and they coming into the primary and secondary and then excreted out through the body. These are the excretion through the glomerular filtration is 20% of our drug gets excreted. The 20% of our drug gets excreted through which? Glomerular filtration in the kidney, through the kidney. Next part we can see there is the 80% of drug is excreted through the tubular secretion. They are the free drugs, they are the plasma protein binding drugs. They are removing. What are the drug binding to the plasma protein? The plasma protein drug are binding, they are not excreted through the dialysis we discuss here. They are not effective dialysis is there. And this is also the drug that are excreted through the body. In which way? Tubular secretion. Free drugs, they are the more free in our blood circulation. Then is the toxicity. They are also removing by the kidney through the tubular secretion. The two ways by the kidney, tubular secretion, and next one is glomerular filtration. Next one is rate of drug elimination. What is the rate of drug elimination? The amount of drug eliminated per unit time. Mean in 1 minute, what is the amount of drug per unit time? It means what is the amount of drug should be eliminated in a given time. That is called as rate of the drug elimination. What is the elimination of drug in the rate of drug elimination is the amount of drug eliminated per unit time. In what time what amount of drug gets eliminated is the rate of drug elimination. Is two ways: the drug clearance and plasma concentration. Drug clearance, how the drug clearance can depend. The amount of plasma is cleared of the drug per unit time. What are the amount of plasma inside our blood vessels? They are cleared. It means the amount of plasma is cleared. It means the removing of our drug. That is the drug clearance. It is ml per hour. What are the amount of milliliters? The amount of milliliters of plasma per hour. What are the amount of drugs should be excreted out from the body? That is the drug clearance. Another one is plasma concentration. How many of the milligrams of drug present in each ml of plasma? In 1 ml of plasma, how many of drug is present and they are get excreted out? They are called as the plasma concentration excretion of our drug, and this is measured in milligram per ml. So this is all about the excretion and pharmacokinetics, our topic. In the pharmacokinetics, we discuss all the 4 parts. First we discuss absorption, second we discuss distribution, ADME, and then metabolism, and then excretion. This is all about pharmacokinetics. In next part we discuss pharmacodynamics and then receptors. About the basics pharmacology, we discuss receptor in it. We discuss pharmacokinetics as well now, and pharmacodynamics is next topic. We discuss everything here in the basic part. After that we start autonomic nervous system. Thank you. Best of luck from my side. See you in next video. Thank you. Bye bye.